Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
Treatments for prostate cancer have been very interesting to watch over the last several decades. One of our panel members that's here with us tonight has been with us since the inception of the show, and really one of the first shows that we did with the prostate cancer show. And you were here with Dr. Horowitz, with Dr. Chesbro and yourself. This is Dr. Vogelweed that we're talking about, and that was in 1997. So for over 26 years, you've been with us. So thank you so much for that. There's always new research and major new advancements with treatments, and as with almost everything, technology has been on the forefront with special treatments. And this program tonight is called Emerging Technologies in Prostate Cancer and Treatment. This program is underwritten by the Rio Grande Urology. And also, I want to say thank you to the El Paso County Medical Society for sponsoring this program tonight. I'm Catherine Berg, and this is the El Paso Physician. Thank you again for joining us. Tonight's title is Emerging Technologies in Prostate Cancer, and Dr. Daniel Vogelweed is with us this evening, who has been with us now for 26 years just doing this show. But you've been practicing urology, and you've been practicing really in this space of prostate cancer for about how long, would you say?
Well, I've been practicing urology for 41 years.
That's all?
That's just all, yeah. And I've been dedicated to prostate cancer for my group for about 7 or 8 years.
Okay. And that's quite a time. We have someone special here that we've been trying to keep a secret from you, who is going to be entering into this room. So if we can have a curtain number 1 open up and have a gentleman that's behind the door walk in. This is our Jeffrey Spear. And I am going to leave this seat for a moment and let him take over. Oh, but by all means, have a good time.
Thank you, Catherine. Thank you. I'll be brief. This is an important topic. I need you to get started, but I want to recognize you. I could spend the whole hour recognizing what you've done for patients, for the community.
I wasn't expecting this.
And for the medical society. So I think it's simple. I'm going to read what is written on this plaque for you. Mm-hmm. We appreciate all you've done, Dan. We really do. And more than anything, I appreciate your friendship. So it says, thank you. Congratulations on your well-deserved retirement, Dr. Daniel Vogelweed. Your leadership, guidance, and integrity will be a lasting legacy for those who were fortunate enough to have worked with you. However, you are most recognized by the quality and professionalism of your advocacy for your patients' health. We wish you the very best on your new journey in retirement. We love you and we'll miss you. On behalf of your staff and partners at Rio Grande Urology and Rio Grande Cancer Specialists and your colleagues at the El Paso Medical Center, County Medical Society. Dan, thank you for all you've done. Really it's special. Thank you. Thank you for your recognition. All right, enjoy the program, everybody.
Good to see you. It's very good to see you. Great. So we were trying to, and Dr. Spear, you're welcome to stay for a little while. We were trying to keep this a secret because he kept talking about the gentleman who's going to walk in the back door. So this has been a lot of fun. And again, as we were talking about, you were very much one of the first people that I met as a host doing this. And I remember joking about you and Horowitz and Chesbro, the 3 bearded men that always talked about prostate cancer.
And the cough drops.
Yeah, and the cough drops.
Yes.
Oh my God, I forgot about that. But this, with Dr. Spear coming in, again, he's past president of the El Paso County Medical Society. Had that show not have been a success, I don't know if we'd be doing this still 26 years later. Because prostate cancer back 26 years ago was not something you said on television. We talked about testicular cancer. That's something we don't talk about. We do now. But at the time, that wasn't something people talked about. And you were as stoic as you are right now. Crack a smile. But this is where that comes from. So thank you from, I think, audience members at home who've been watching you and been around you for all this time.
Well, it's been my pleasure, really. And to me, it's always been, what can I do to inform my patient? And if I can inform my patient and help them in any way, I can't ask for more than that.
And you're always, when you talk about terminology, you always bring things to an understanding where everybody gets what you're saying, which I thank you for as a person who hosts. And now, Dr. Travis Mendel, now you get to be introduced, but you're like the young one, right? And so we were talking about that quite a bit too. So Travis Mendel, his technical title is radiation oncologist. And again, that's Rio Grande Cancer Specialist, which is under the umbrella of Rio Grande Cancer Urology. So thank you for being here. I know that we talk a lot on this program just about things that are new and things that are coming up. And tonight's program is very specifically about that. On that note, and Dr. Vogelweed, I know that we do this every time we do the show, but I think it's so important as a trained urologist for 41 years, goodness. Let's talk about where the prostate is, what the function of the prostate is, and it's just a good hop into why it is that we look at screenings, why it is that we look at what the issues of the prostate are, not just cancer, but we're going to start off with issues of the prostate that aren't cancer yet, that can become cancers, and then we're going to go into all of the oncology stuff. But would you like to take it from there?
Sure, but there's one thing I'd like to do first is I'd like to welcome Dr. Mendel to the Fellowship of the Beard.
The Fellowship of the Beard. You know, I didn't even think about that. He still looks like he's 12 with a beard.
Well, he reminds me of when I started out in practice because I didn't have a beard and I grew a beard and they no longer told me I looked too young to be a doctor.
Oh, look
And
at
then I
that.
found out from Brian today that that's one of the reasons why he grew his beard. So welcome to the fellowship.
What was the name of that? Doogie Howser, MD?
Yeah.
Remember that? When it's like when you're a young looking doctor, people just like, but
Yeah,
I'll tell
I
you
get
what,
that
if
a lot.
anybody wants to look back, and I talk about this a lot toward the end of the show, but if you want to look at urology programs or prostate cancer programs, the things that you've come, I usually watch a prostate cancer program prior to doing this program because I like to be prepared. And you just knock it out of the park. The first time I met you, I thought, this guy is so young. But then you know stuff. And then you're not old, but you always call yourself the old one. But to just bring this as a combination
I
together,
resemble
it's
that
lovely.
statement.
I resemble the statement. And then what Dr. Jeffrey, Dr. Spear somewhere in between, which is always kind of nice
He's
to
only
have all
20
three.
years younger than I am.
That's it.
That's it.
That's it.
He looks only about 10 years younger, but he's 20 years younger. He already left.
Oh, gosh. So let's talk about the prostate, which is why we're here. What is the function of the prostate?
The prostate is part of the male reproductive system, or if you want to call it that. And it is a sex organ. You would not be able to have any children if you didn't have a prostate. And it functions as basically, most people know this, but your testicles make sperm, and your sperm comes out through the urethra. Well, it comes out through the urethra. It has to go through the prostate first. And the seminal vesicles in the prostate add nutrients and lubricants to the semen as it comes out so that it can make it on its way into the cervix and uterus and ovaries in women. You can see from this diagram, it's kind of small, and I apologize for that, but this is basically the bladder right here. This is the prostate. You can see that right through the prostate comes the urethra that comes out to the tip of the penis. Well, and these are the seminal vesicles that are sitting behind the prostate. They're usually not this big compared to the bladder. The prostate's probably equivalent to an empty bladder, but when the testicles make the sperm, it comes out through this duct here in the prostate, and the seminal vesicles contribute to that. The seminal vesicles also contribute to storage of semen, and they could start contracting when you ejaculate, and that's basically the function of the prostate. But unfortunately, one of the things that it does is it develops cancer.
Right, exactly. So when we're talking about, and it's interesting too, because you're looking at women, and there truly are age-bearing years for women. For men, that's not the case. You're always going to have the prostate. You can have children. I want to talk about Al Pacino and who is it, De Niro? I'm not sure. But yes, I see a stutter start in Dr. Vogelweed.
No, it's not a stutter. I was just thinking of an older actor who had kids when he was 80 some years old, and he's dead now, but I can't think of his name. but I'll think of it.
But it's an active blend. You know, after the age of 50 something, women we're put to pasture when it comes to that. So when we talk about the prostate,
you know, it just shows you. Well, I won't say anything.
oh, come on. This is your retirement show. You can say anything you want.
God, he's a famous actor, and I can't think of his name.
It'd come to you like in 20 minutes.
When they gave him an Oscar, an Indian woman came out on stage and said that she wasn't going to accept the Oscar because he didn't want it. And I just can't think of his name right now. Famous actor. Died a few years back. I think he died in Tahiti or Fiji or someplace like that.
Oh, my goodness. You know what? Somebody at home right now is Googling it and shouting it at the screen. Yeah. And we're like, oh, dang it. We don't remember what it is. But we have to. I would Google it right now, but I want to keep going on this.
Brando.
Oh, Marlon Brando.
Yes.
Really?
Yes.
Okay. Had a child at 86 something?
He had 2 children after the age of 80, from what I understand.
Okay.
And then you've got Pacino and you've got, you know, it's possible. It's not 100%.
Right.
But it is possible.
But it's still a functioning organ. You know, at the end of the day, we're kind of focusing in on that. When you start looking for screenings of prostate cancer, and kind of why I was bringing up the 50-year-old and women, et cetera, 50 seems to be the controversial age. The American Cancer Society and other organizations like, well, when do we start screening for prostate cancer? And then there's high-risk age groups, high-risk ethnic groups. What is now the screening golden standard when it comes to prostate cancer? And Travis, I'm going to throw that one your way. Or is there a golden standard? Is there still a lot of controversy around that?
I mean, the controversy stemmed from the task force, like back in 2012, when they decided that the PSA screening wasn't worth it and it was causing more morbidity for patients, leading to more biopsies and things like that. But I think that's now been somewhat debunked, that PSA screening is important. In general, most men or most providers will start screening at age 50.
Okay.
But there are high-risk groups, like you said, especially genetically high-risk groups. And so that's, you know, why we do a lot of genetic screening nowadays.
And what are those groups? If I remember right, the Ashkenazi Jewish population, is that correct?
Yeah, you can have that. But I mean, there's patients, you know, especially patients with a family history of cancer, especially prostate cancer in a first relative. That's very high risk. You know, we do a lot of screening for kind of high risk mutations. BRCA mutations is a big one. And that's also very relevant in breast cancer as well.
You know, and I remember us talking about this a couple of shows back. So the BRCA gene, I feel like several years back, we only talked about that with breast cancer. And now we're looking at that as not necessarily sexual organ cancer, but just other glandular type cancers. Is that correct? So is that still a practice? And we're looking at it's not technologies per se, but it's definitely a new way of looking at screenings. Is that still how that's going?
Well, just for like screening for cancer, you know, PSA is really what's used in the digital rectal exam. But in terms of just basic laboratory tests, PSA is really the main one, at least from my understanding. But really, what you know, when I'm speaking with patients about their lab values, everyone's very focused on PSA. You know, even after treatment, before treatment, it's, you know, this test was designed as a screening test, and we use it as a tumor marker as well. But it's the PSA. It's really just a number, and it really, when you're tested for PSA, there's a number of things that can actually increase your PSA. Ejaculation, you know, shortly before. If you had a digital rectal exam shortly before you were tested, all these things can actually raise it. So, you know, patients are always very anxious about their PSA values, and they can really fluctuate quite a bit. And so I think it's just very important to make sure that once you have your PSA tested, if it's elevated, it's important to make sure that it remains elevated, because these, you know, different actions can actually raise it.
You know, that's an interesting, I've not heard that before. So on that note, if somebody knows that they're getting in, so PSA is prostatic specific antigen. It's a simple blood test. You know, no blood test is simple, but it is a simple blood test. If there are there, for example, if they know that they're going to have their blood drawn on Friday, are there any ideas or a sheet that says, you know what, maybe abstain from sex for the 3 days before, or don't do this, don't do that prior to the blood test? Is that even something that's written down somewhere? Or is that discussed with the patient prior to having their PSA
I would hope
blood
it would
test?
be.
Yeah, because I've never heard of it. So I just thought that might be a question to throw out there.
So the majority of patients who are undergoing screening are actually being seen by their PCP.
Okay.
And so I'm sure it's very variable, that they're
Okay.
just kind of adding it on the lab test because they saw the patient's 50. I'm sure a lot of them will mention it, but it could easily be missed.
Right.
But this is probably what happens is the patient has an elevated PSA screening. They're sent directly to the urologist.
So that's a perfect transition to
That's
Dr.
when-
Vogelweed.
Yeah.
So now we have someone who is, let's say he's 55 years old.
Let me just add
Yes,
to what he
please.
said,
Uh-huh.
okay? Another thing that can affect PSA is the size of the prostate volume.
Mhm.
The bigger the prostate, the more likelihood the PSA is going to be elevated. The biggest mistake that even PCPs make nowadays is if you look at a laboratory test and they're going to tell you the normal value is from 0 to 4, and above 4 is abnormal. That's not true, okay? If you have a 50-year-old that has a PSA of 3, he has a high risk of prostate cancer.
Oh, really?
Yes.
Okay.
Generally speaking, if you have, at any age group, if you have a PSA of less than 1.5, your risk of prostate cancer is very, very low, and you probably don't need to repeat it for 5 years. Okay? Certainly if it's less than 1. Even if you have a family history, for that person, that risk is not that high. I would probably check it more often if you have a BRCA abnormality. But that, generally speaking, number one, check it at the age of 50, check it at the age of 40 or 45, depending on who you talk to. If there's a family history, if you're a black male, if you have Ashkenazi Jewish ancestry. Okay, even if you don't have a genetic abnormality, okay, if your father or your uncle or your brother has prostate cancer, you're at increased risk.
Absolutely.
And you should be checked at an earlier age.
So here's a question. Let's say an average 25-year-old male, if for some, not that he would need it, but if you were going to take a prostatic specific antigen, a PSA test on him, would there be even a number? Would he register even? If it's somebody that, okay.
Yeah, they'll register, but it'll be
Okay.
a very low number, generally 0.3,
Under 1?
0.4,
Okay.
yes.
Okay.
And, there have been instances where very young people have prostate cancer. I've never seen one.
Yeah.
I think the lowest I've seen is in their 40s.
Oh, okay.
Yeah.
All right.
And they're flukes if they're younger than that. It's very, very unusual.
So now we have a 55-year-old that has a prostate or has a PSA, and let's just say it's at a 7 or an 8. So we now know that, sent to the urologist, you see him. What do you do from there? Like, what are the next steps? Conversation leads to A, B, C, and D.
Well, the first thing I would probably do is, in addition to history, family history, so on and so forth, I would check his prostate and see if it's suggestive, if there's a nodule on it or anything like that.
So physically go in, digital rectal exam.
Do a digital
Okay.
rectal exam, because that can give you an indication if he's got this huge prostate. The other thing that you may consider, if you think that person's low risk, is repeat the PSA. Okay, it could be a lab error, or it could be that he was riding the bicycle before he came into the office.
See, again, a risk factor I didn't think about, not risk factor, an elevation factor,
Yeah, well, I mean, because
guess.
it's direct perineal pressure of the prostate. It's just like, if you're doing a prostate massage or you're pushing on the prostate, it can elevate your PSA.
Okay.
But then in addition to that, if it's borderline, there are additional tests that you can do.
And what are those?
There's a PHI score, there's a PSMA3, there is a 4K score. I don't know, you don't use a decipher for that. But you can do those tests and they can tell you whether it's low risk or high risk. Ultimately, it depends on when you see the patient, whether you think or not, whether you should do a biopsy or not. And then we get into the next thing. Do you go directly to biopsies or do you do an MRI first? I would probably...
That's the question right now.
I would probably want to do an MRI first because it may identify a really significant focus. And this is also controversial too, because if your MRI doesn't show high risk, should you go ahead and biopsy the prostate or not? If your MRI has high risk, should you also biopsy the areas of the prostate that don't show it? And these are things that have been discussed back and forth in the literature. Ultimately, it comes down to the urologist and the decision he makes as to whether to biopsy him or not, whether to do an MRI or not. And that's variable.
And so if you're looking at what is your truly alarming number when it comes to a PSA elevation, like when you're like, you know what, MRI or not, we're gonna do a biopsy. Is there just like 14, 15? What is that crazy number?
I
that
would,
is-
if I go back, I would probably say that I wouldn't even think about it. There is an exception there. You can have a 10, 15, 20, 30, and then have an infection.
Oh, good point.
And
right.
a prostate infection can make your PSA go up.
Mhm.
But if the urine is clear and you have no infection, absolutely, I would probably biopsy anybody who has anything above a 10,
Okay.
maybe even lower than that.
Okay. And that's kind of where I was getting at as far as that goes, because the biopsy is always that thing that people take a big breath for. It's like, oh my gosh. And so now, Dr. Mendel, somebody has a biopsy. It does come back that it's positive. There's definitely cancer in the system. And so next steps from there.
So usually, well, I guess I can just backtrack a little bit. Like with the MRI, I'm a huge fan of imaging.
Mhm.
We use imaging a lot for what I do. So I'm a big advocate for getting MRI before biopsy. And it's been shown that the MRI is able to identify higher grade disease.
Oh, good.
And
Okay.
that's why it's really important, because you can find these patients that have higher grade and better risk stratify them for treatment. When you do a template biopsy, it's more of a systematic sampling of the prostate, and so you're going to find more prostate cancer, but a lot of it will be low grade. And it'll still be, sometimes low grade on the MRI, but it kind of gives you a sense to kind of where to maybe take additional samples or something like that when you're doing the biopsies.
Mhm.
And when you're discussing treatment options for patients that have been diagnosed with prostate cancer, it's very important to risk stratify them, because they're
What
really.
does that mean? Risk stratify them?
So basically, figure out how aggressive their cancer is.
Gotcha.
Because
Okay.
there's a very wide spectrum. We think of things. There's Gleason scores, which everyone's heard of.
Mhm.
6 and above is prostate cancer. We now kind of think of these scores in terms of grade grouping, and there's 5 grade groups. But basically, if you're a low risk patient, which is essentially a Gleason 6 or a grade group 1, those are almost benign entities, and a lot of those patients are now pushed towards something called active surveillance.
Okay.
Which is a treatment modality for prostate cancer. They're really trying to de-escalate active kind of therapies for patients that can just be watched, because there's morbidity associated with surgery. There's a morbidity associated with radiation, and so if you can kind of kick the can down the road for a couple of years or even a decade, a lot of patients safely, then a lot of patients will choose that option.
So during active surveillance, how often do they go in to get rescreened or to relook at? And what is it that they're looking at? Are they doing PSAs each time? Are they doing MRIs each time?
So there's different guidelines.
Okay, of course there are.
So everyone,
We can never make this easy,
yeah,
right?
Everyone has their different way of doing things. The way that I do it is, we of course make sure that we know all the facts about the patient's diagnosis with imaging, and biopsies. So typically what happens in our practice is the patients will have a template biopsy. It'll show some type, low grade cancer. A lot of times they'll come to me and I'll discuss this with them that, hey, you're probably a candidate for active surveillance, but I'm going to get an MRI and make sure that we're not missing anything.
Right.
And it's, a lot of times the MRI looks fine, and we'll do additional testing, genetic testing, molecular testing, which is the Decipher test that Dr. Volga was talking about. That is more of a kind of a computer-generated risk category for the patient. But basically, we make sure it's safe before they go into active surveillance.
Okay.
But once they're there, the way that I approach the situation is we repeat their biopsy 1 to 2 years after their initial biopsy to make sure that their cancer hasn't progressed, and it can progress in size, like number of cores taken. So say they had 1 core of a Gleason 6, and then they come back and now they have 4 cores of a Gleason 6.
So
It's gotten
explain
bigger.
what you mean to those that don't know what the cores taken mean. So
So basically, when you get a template biopsy, most patients will get 12 samples taken from the prostate
okay.
in systematic areas, and it's basically creating a semi-map of the prostate and letting you know, okay, in this part of the prostate there's cancer. This is what the pathologist thinks how aggressive it is, And then in this part of the prostate, we didn't really find anything. But nowadays, we're catching prostate cancer quite early, and so some of the lesions can be very small, and the prostates can be huge. And so when you do these template biopsies, sometimes things can get missed. And so that's why, in my opinion, the imaging is very important, because if you're dealing with a small lesion, whether it's low grade or high grade, you want to know that it's there, and you can watch it on active surveillance.
Exactly.
So
It's kind of important to know that this is getting into a lot of the complexity that we really face, because it's not just simple, straightforward. If you go back to historically we used to do transrectal biopsy. We didn't even have ultrasound. We just stuck our finger in. If we felt a nodule, we'd put in the needle above the finger and stick your finger sometimes.
Wow. Okay.
Then we got ultrasound. We started with 6-core biopsies, and then we went to 12-core biopsies. Some people use templates and they do 24, 48, whatever number of biopsies. We used to use a lot of these saturation biopsies before we had used MRI a lot. It used to be also that, before the United States Task Force for Prostate Cancer came out and said you shouldn't biopsy anybody, we would biopsy, and if we found cancer, we would treat everybody, because we really didn't know how they did historically.
Right.
And that's where
When you say this, give me a year approximately. Like how many years ago are you talking about?
Well, before 2012, so
Okay.
before
So
that,
really not that long ago.
not that long ago.
Okay.
No.
All right.
And nowadays it's really complex, because there are a lot of things that you have to take in consideration. The complexity is a little bit too much to go to or to try to understand on this show, I would think.
yeah.
And but I guess the most important thing that you need to know is, yes, you should. Every male should be checked after they turn 50. At the least once, they should have a PSA done. There's controversy now as to whether you should do a digital rectal exam. Well, if you have a very low PSA, you probably don't need to have it done. But if you come in with a high PSA, I'm certainly going to check the prostate. I mean, not ever check it again, or I may check it again if I'm following them. And when he talked about Gleason 6 tumors, which is a grade group 1,
I heard a grunt come from you.
well, yeah, some people. This is not me.
No.
Okay?
Again, this is why this is so
but it is
controversial to have this.
Some
I'm
people
with you
think
on
that that's really not cancer.
Right.
Okay, and I'm not sure. There's no way in the world that I know of any urologist that say, "Oh, that's a Gleason 6. I'm not going to follow him." Okay, but there are people out there that say, "Well, that's probably not cancer," and a lot of those people do well for a very long period of time. But yes, they should be followed.
Mm-hmm. So let's take it now to, as a surgeon, and I always look at, or at least in the old days, I thought to myself, okay, Dr. Vogelweed, the urologist, he's the surgeon. So when is it that, then I want to go really into the new technologies that are going on, but when is it that a gentleman has to really decide whether I'm going to have my prostate removed or not? Talk us through that process with the patients that you've dealt with 20 years ago up until this past year, and what the differences are.
Well, 20 years ago, anybody had prostate cancer we operated on, unless they had metastatic disease.
Okay.
And even there we get into all the changes, because we used to relied on bone scans and CT scans to diagnose metastatic disease. Now we have a PSMA scan, which is about 38% more accurate in diagnosing prostate cancer metastases. And so most people will, particularly if it's high risk, they'll do a PSMA to see if there's any metastatic disease. If they have metastatic disease, then probably not. But it depends on the situation again, because you can have oligometastatic disease, which is something that he loves, because you have two options there. If you have 1 or 2 positive nodes in the pelvis, well, you can still do a radical prostatectomy and take out those nodes surgically.
Mm-hmm.
Or if the patient's 75 years of age, or he's 55 and he's a bad diabetic and his kidneys aren't working well, you can treat him with radiation and radiate those nodes.
Mm-hmm.
And it also depends on the patient preference. Some patients are deathly afraid of radiation. Some patients are deathly afraid of surgery.
Right.
And generally speaking, if you do not have metastatic disease and you're relatively young, a urologist will say, well, let's take that prostate out. Now, the younger the person is, the less likely it is that they're going to have the complications. The 2 main ones they're concerned about are impotence and incontinence.
Mm-hmm.
Okay? But if you compare, if you get a 60-year-old or a 70-year-old and you give them radiation or you do surgery, generally speaking, long-term survival of the first 10 years is exactly the same.
I remember us talking about that years ago even. And that is that still the case? And now this is a good transition into some of the things that we have written down here. So there's something called theranostics.
Theranostics.
Theranostics. So Dr. Mendel, can't call you Travis. What is that? Because that's something that's relatively new to me. I've seen it, heard about it here and there, but I know very little about it.
So this is a technology that's actually been around for quite a while, but it's starting to kind of pick up in the prostate cancer space.
Mm-hmm.
And the concept is to use imaging to identify cancer in the body. And in our world right now, we're using PET PSMA,
Right.
which has completely changed my practice.
Huh.
Everything. It's changed everything I do. It's changed how how I treat the patients. It's just really been. I thought it was going to be big, and it's
what
bigger
else
than
are
I
you
thought.
able to see using this versus in the past?
So it stems all the way to the actual, actually risk stratification, because this is a staging imaging. And what Dr. Vogel was discussing before, we had CT and bone scan, which were essentially useless unless patients had, a massive bony disease or, very advanced, a very high PSA. Usually they're completely useless when we're finding these cancers so early. And so now we're using real staging imaging, and PET imaging has been around for a while.
Oh my gosh, yeah.
We use it in a lot of other malignancies, very common
Mm-hmm.
for staging. We just didn't have this technology until like early last year, at least here in El Paso.
It was just approved within the last year.
Yeah.
Wow.
So
is it an imaging machine? I mean, maybe
It's
describe to us what it looks like, what the process is when somebody gets this imaging done.
it's basically it's like a CT scanner.
Okay.
But it's souped up. It has a camera, and basically you're giving patients a radioactive isotope that creates positrons, and then you're able to detect that
Okay.
in the patients.
What you need to
Let's talk
understand
about
there is that PSMA stands for prostate-specific membrane antigen.
Membrane.
Yes, and it's an antigen that's what they call a transmembrane antigen, but it's on the surface of the cancer cell. And so what this does is that it sends an antibody to that antigen and lights it up. And it can be any place in the body. It can be in the bones, which is the most common. It can be in lymph nodes, or it can
And
be.
this imaging picks that up that you're talking about.
Yeah. So
Oh, my.
the prostate cancer expresses this antigen,
Yeah.
and so you're able to tag it and target it.
Now, pardon my ignorance, and I just want to make sure that I'm understanding it correctly. So are we talking about metastasis, or are we talking about just the idea that when you
Yes.
said, so this is metastasized to other parts of the body already, and this imaging can pick that up?
And it could also pick it up in the prostate, or it can pick it up in the prostate bed after the prostate's been removed if you have recurrent disease.
Okay.
So
Okay.
it's really
Wow.
so I can't remember if I talked about this guy last time, but I had this patient who was in his early 60s, late 50s, had a rising PSA for almost a decade and had gone basically undiagnosed. And he'd seen our physicians several times, had multiple biopsies, saturation biopsies, went to Mayo, went to MD Anderson, had all these fusion MRI biopsies, nothing. And when he came to my clinic, his PSA was 50.
Dear Lord.
And he had,
but nobody can find anything. Like where?
no, one of his original biopsies, they found a very low grade 1% of a core, and they put him on active surveillance very appropriately.
So even at 50, he kept his prostate this entire time as
Yes.
it was climbing up.
Well, yeah, his PSA just kept going up. They couldn't find anything, so no one really treated him. And he came to our clinic, and we got a PET scan. And in the very front part of the prostate, it lit up.
Oh, wow.
And so I went in there and biopsied it, and it came back as a relatively high grade prostate cancer. He was high risk, and we treated him, and he did great. But this imaging, it's really just changing a lot of the things we do. Because that patient was, basically undiagnosed. We were able to diagnose him, risk stratify him, and treat him appropriately based off of his risk. And so it's really changed everything.
I bet.
But this is the theranostics has been around for other malignancies, but it's now kind of just transitioning into prostate cancer because we have something to target.
Okay.
So we have the PSMA scan that's able to allow us to see these cancers in the body, whether they're localized in the prostate or in the bones or elsewhere in other organs. But now we have a radioisotope that we can tag with the PSMA, the lutetium. And that actually
Lutetium.
goes.
Yeah, the term theranostics is used because it tags, but it also is therapeutic, because that's what he's talking about.
Yeah.
Oh, okay.
He'll explain.
Okay.
Yes, but they've been doing this for a while, and like thyroid cancer is a type of we use radioactive
Same shape.
iodine. Patients who have metastatic thyroid cancer, most types of metastatic thyroid cancer, you can give radioactive iodine, and that treats the whole body because those cells take up the iodine. The lutetiums actually come off of what's called a dotatate scan. These are patients with neuroendocrine cancers. They're like kind of a GI
These are
cancer.
patients with what kind of cancers? I'm sorry.
Neuroendocrine cancers.
Neuroendocrine. Okay.
But basically, we don't need to go into the neuroendocrine cancers, but they use this scan to find these lesions, see how many they are, and then develop a therapeutic that's radioactive that you can infuse in the patient, and it goes straight to those tumor cells.
So when we use the word therapeutic, what we're basically saying is a treatment, unless I'm wrong. Is that correct?
But that's why it's called theranostics, because I don't know why they came up with that term, because it's basically the same thing as the PSMA. The PSMA, the common ones are polarify and the gallium. And the thallium or lutetium is if you give it to the patient, it will light up where the cancer's at. But since it actually gives out radiation, it can also treat the cancer cell, and that's why they came up with the term theranostics.
I see.
And it's very nice to
So
have it
we're
in
gonna
our
be talking about
armamentarium
this.
whenever we get it.
So it's coming in the next couple of weeks.
Well, that's great,
look at
because I've
you.
got about
Yeah.
4 or 5 patients. You probably have a whole bunch waiting
I have
for
a
it too.
list. Yes,
Carry
I
on
have a
this
list.
conversation that you're having right now. Honest to God, because I think this is fascinating to me, because how often on this program do we get to hear that you're excited this is coming in the next couple of weeks? Do you have some patients right now that are going to be using this therapeutic?
Okay, let me go through it stepwise.
Okay, please. Yeah.
Patient comes in, patient is referred to me with advanced prostate cancer.
Right.
Okay. The treatment that's been around since I think 1942 is blocking the male hormone. In 1942, they removed the testicles. And they found out that the people lived longer if you removed the testicles. And then in the 1980s, they came out with the injection of Lupron, which is also used for
remember
breast
that.
cancer, if I remember correctly, or
Right.
it's definitely used for endometriosis. But anyway, and so we use that instead of removing the testicles, and that's all we had. If you have somebody who has significant metastatic disease, their average survival is a year and a half to 2 years if you put them on this injection or you remove their testicles. Then we came out with bicalutamide, which is basically an androgen blockade medication, uptake blockade medication, and initially it would complement the Lupron, but later on they found out that it didn't have any effect on long-term survival. And then they came out with these second-generation anti-androgens, enzalutamide, darolutamide, and apalutamide. And these basically go to the cancer cell, and they keep the cancer cell from using the testosterone that's available.
Almost like blocking it?
Yes.
Is that what you're saying?
Well,
Okay.
it doesn't allow the cell to use it. It blocks it
Okay.
to 3 different levels in the cell. But what you need to understand is, and this is simplifying it, but when you give a patient a shot of Lupron, it basically tells the pituitary gland to tell the testicles not to make any more male hormone. And about 95% of the male hormone is made by the testicles.
Right.
But a certain amount of male hormone or its precursors is made by the adrenal glands. And that male hormone can be utilized by the cancer cells. So this blocks it, and this extends their survival. I've had patients on this medication for 6 and 7 years now. Okay. And then that was the next step. And then initially, then there's chemotherapy. And usually it used to be that after the Lupron, if it stopped working, the next thing was chemotherapy.
Exactly. Right.
Okay. But now they found that one of the first medications was actually a synthesis blockade. I'm making it confusing, and I apologize for that.
Well, no,
But-
I think this is so good for a setup, because this has never been the same show. We've done this show, we were joking 26 years, but we've probably done a prostate cancer show 30, 40 times. And it's different every single time.
And
because
that's
of
what's so exciting about it.
It is, isn't it? It's so complex. And I can't even imagine if you have 10 patients. I know you have far more than 10. It's like each one of them is being treated very differently than the other, depending on all the
Yeah, they're
variations
variables,
there.
but that became what we call bimodal therapy. And then they
Okay.
came out with trimodal therapy, which is basically is a combination with chemotherapy plus Lupron plus androgen uptake blockade. Then is from the radiation side, they found that people that are put on, and I should let him talk about that, but they put them on Lupron in addition to giving the radiation, they did better and the patients got radiation alone. Then they found that if they add this androgen synthesis medication, that even gives them better response to the radiation therapy. So it's become, and so anything that happens that's good is exciting, and there's research on it every single day. And so, but, we're here sitting, oh, I need this now because I have these patients and I want to help them. And that's the frustrating part about it. But on the other hand, I didn't have any of this stuff 10 years ago.
Right. And so, Dr. Mendel, your eyes lit up like 3 weeks from now, and you're looking at Dr. Volk. It's going to be like 3 weeks.
Yeah.
So
it's very soon.
Going now into all these different treatment options that are going. So radiation, and I think in and of itself, prostate cancer, for the way I look at it, uses so many variations of radiation for treatments. And I know this new stuff's coming up. So just kind of go on a tangent on that specifically. Because a prostate, again, is the size of a walnut, right? So you're looking at breast cancer, and granted, the tumors are, it's not the organ, it's how big the cancer is or how big that is. But the different types of radiation from when you started to what's happening 3 weeks from now.
So basically, I mean, it's very complicated. It would probably take a while to explain everything. But the way that I run my clinic, there's a couple of things. One, it's all about personalization. Now medicine is all personalization and precision. And so all the treatments we do, it's all about, making sure that we're giving the patient the correct therapy. So that's why the risk stratification up front is very important. Because you can escalate therapy as much as you want. Some patients will benefit from it, some patients won't, but we know which patients will. And so that's why it's important to identify those patients before you do anything. Okay. With just localized treatments, we have surgery, but there's multiple radiation options. It's all personalizable. And all the patients that come to my clinic, they come in, they actually have a pre-recorded video that I made on PowerPoint that they watch. It's both in English and Spanish, and it goes over all the treatment options. And the goal, like when I came here, the goal was to bring all the treatment options that I learned in Dallas, actually, here to El Paso, so people don't have to leave.
Right.
They don't have to go anywhere to get something different. And the only thing that we've been missing, is research. And we're actually starting a research program here very soon. We hired a PhD.
Oh, good.
So we're going to be participating, or at least attempting to participate in
one more thing that we're doing
hopefully these
here.
like national trials, and so patients won't have to leave to get their prostate cancer treatment.
Right.
They can get it all done here, and we do a very good job. And we going from just external beam to hypofractionation to stereotactic treatments, where we do our treatments in just 5 treatments. All the way to brachytherapy and conventional treatments. So we do everything, and we do it very well because I treat all cancers. I treat breast cancer, lung cancer, brain cancers, but cervical cancer, endometrial cancer. We have a big gynecology program. But basically, our goal is to make sure that the patients are getting the right care, and it all starts from the beginning. But once you transition into this metastatic space, it becomes very difficult to cure the patient.
Right.
And Dr. Fogelweed always likes to poke fun at me about this because I think I can cure everyone.
And never lose that.
Yeah.
I mean, truly, you want that energy in every doctor.
And it's not that I think I'm going to cure them, but I do think I'm going to help them. So
that's the important part.
Yeah.
You have a lot of these things are life prolonging. Okay.
Yeah.
They may
Quality
not
of life
necessarily
prolonging
be
as well.
quality of life. They
Right.
may not be curative, but as I said, 1.5 to 2 years. Now, if we're getting 6 and 7 and 8 years, this is a blessing. And I have to second what Dr. Mendel says about clinical research. In my clinic, that's really essential. You have to be able to participate, and it has a double value. Number one, you have more things to offer your patient. They may or may not work.
Right.
Okay, but at least it offers them something else. And then the same thing goes for radiation. Then there are these combination programs. Combination, like I was talking about one medication that he uses in combination with radiation therapy plus the injection. Well, the other three medications have also been proven to be beneficial, at least enzalutamide, which is one of the first ones that came out that was an androgen uptake blocker. And every opportunity that you can offer your patients is an opportunity not only to help them, but also to help everybody, because this is where we learn, and this is where all of our patients benefit.
So when you're looking at, again, with these treatments that are on the forefront, and I know that in days past, they didn't like using the word cure with cancer. And when you're looking at prolonging a life and you're looking at quality of life, Dr. Mendel, I'd love for you to talk about what you see coming. I know we've got all this stuff happening in the next several weeks, but if you could take a magic ball, what do you call it? The glass ball. What do you call that thing? Dear Lord, the globe. And say 10 years from now, we need to cut this part out probably. 10 years from now, we are on the forefront of treating all cancers, because I know this is a prostate cancer program, but you are treating all cancers, and some of them are similar. What is it that you see 10 years from now that's really going to knock it out of the park? Because I feel like that's happening right now. If we were having this show 10 years ago talking about this, do you think that even would have been something? And Dr. Vogelweed, you were here from the beginning.
There's one thing that I hadn't mentioned before he answers.
Yes.
We also have monoclonal antibodies.
Say that slower.
Monoclonal antibodies.
Okay.
Particularly the patients that, and then even some of the patients that do not have a genetic abnormality. If they do, then there are the most commonly known one that works in a whole bunch of cancers is pembrolizumab, which is they've used it for prostate cancer, renal cancer, bladder cancer. I don't know how many other cancers, and basically it's an antibody against one little antigen. And it does work. In prostate cancer, the one that's approved across the board for BRCA1, BRCA2, ATM, and about 14 others is olaparib, which is called Lynparza, and I think they even have ads on TV. But that is big for lots of cancers in the future. And so it's just one more thing that we have. Unfortunately, it only works for people that have genetic abnormalities, the best. Inheritable genetic disease.
Right. And Dr. Mendel, I'd like to talk with you about that too, because I feel like you have so much research on what's going on in the world of genetics. And so when we're looking at prostate cancer, yes, family history is a big thing, but we're also looking at that's a relatively small number of people. I mean, getting older, living a little bit longer is where the risk factor is. But if you're looking at genetics, if your father had prostate cancer, what are your chances? Or if your uncle had prostate cancer, what are your chances? And in the world of genetics, we always talk about that, but it's not as big as people think. It's not the large number of the population as people may think, correct?
Yeah.
Or how would you describe that?
I probably couldn't give you a percentage. I don't know if
about 30%, 20 to 30%, if you have an inheritable trait.
If you have an inheritable
a BRCA2,
trait.
you have an ATM or BRCA1, which is rare.
So this is that testing you have to see if you happen to have a gene that is easier to mutate than others that do not have that gene. Is
Correct.
that correct? Okay.
But I can't tell you exactly what the risk is percentage-wise if you do not have an inheritable disease, even though it's increased compared to the rest of the population.
Okay.
But definitely there's an increase. I mean, I see, and I'm sure Travis has seen it too, there are patients that the father and uncle and one of the brothers has prostate cancer, yet they have no inheritable trait. The problem is that we know very little.
That we know of, right? Yeah.
That we know of. That's what I was getting at. The problem is that, one thing is having one gene, but how about combinations of genes that predispose you? Okay.
See, that to me is what the 10-year process is. Like, what are we to know 10 years from now, specifically with this kind of testing?
Well, we may know a lot more than we'll most likely know a lot more than we know now. But how many genes are there in our gene pool? Okay. So how many combinations? And then you get into the SNPs, which is small nucleotide, something or the other, which also has something to do with inheritable disease. I don't know. There's a lot of research, and the more you learn, the more complicated it becomes.
Of course. Right.
Yes,
Dr. Mendel?
I see 10 years as like, it's just going to be more precise and personalized because we're going to have more information about the genetics. And, we talked a little bit about germline testing, like your heritable genes, but there's also the tumors genes. And that's somatic testing. And there's already targets for different mutations and for those patients, but they're gonna find more.
Right.
Right. So in 10 years, I see this realm of, we're always going to have our tried and true local treatments. But I think in the future, it's really going to be the patients that have metastatic disease that are incurable, and we're able to give them these life prolonging therapies. And it's even now, it seems like we're treating almost like a disease, like a diabetes,
I was going to say
or
something that's chronic.
hypertension.
Hopefully it could be something like AIDS. Remember how
Right.
AIDS was
Yes,
deadly
it
for
was-
everybody?
Exactly.
And now you can
Yes.
live, as long as you're on medication, you can live a normal lifespan.
Right.
Just real quickly
Mm-hmm.
on genetic testing and what we call germline mutations and somatic mutations. I've had we always do germline mutation when anybody has advanced disease. That means that every cell in your body has that genetic abnormality.
Every cell in
every
your
cell
body
in your
does.
body. That's why it's inheritable, because
Okay.
and if a parent has prostate cancer, his son has a 50-50 chance of carrying that gene. Okay.
Okay.
Because he gets part of his gene pool from his mother. They get 50-50 or whatever number you want to call it. And that is inheritable disease. But you can also have a genetic mutation in the cancer itself. Okay. Whereas you do a germline on the patient and it's negative. It says nothing that we know of is causing it. But then you do a somatic test, which is done on the tissue itself, or you can also do what we call a liquid biopsy, where they look for DNA fragments of the cancer cell. And that may give you a genetic abnormality that's treatable.
So is this all being done on the cancer itself, or are these done as testing to see what your chances are of what treatment options are? Or is that?
It's done as it will, about 15%, 12 to 15% of all advanced prostate cancers theoretically have inheritable disease.
Okay.
In my practice, it's about 8 to 10%.
Oh.
Okay.
Okay.
And those patients, it gives me an additional form of treatment in the
okay.
future, or in some circumstances, you can start out with that treatment right away. But I have 2 or 3 patients that do not have an inheritable disease, but they actually have a mutation in the tissue. The way you find that out is you can actually, when they do that, and Travis does this, thankfully, he does, when he sends his patients in for the biopsy, if they have a high-grade disease, he also sends a test tube with their blood so that they can see if there's a germline mutation.
Right.
And then in the future, if he develops it, if he's not cured and he develops advanced disease, well, then you can do somatic tissue on that testing. Or if it's more than 10 years, then you can do a liquid biopsy, or if he has a very large lymph node, you can biopsy that and do somatic testing to see if there's been a mutation.
And the key is as the, I guess the theory is that as the cancer becomes more aggressive, it picks up more mutations. And that just gives you more opportunities for targeting it with some kind of therapeutic.
Correct.
So it's almost that as it gets worse, it's easier to treat. Not
Usually
easier.
no,
It's there. You have more options
but
at that point.
It's more like, I guess you could say it can pick up mutations that can be treatable.
Okay.
And it's a twofold approach now, because now we're looking at the genes in the cancer, like the actual genetics of the cancer. We're also looking at the cellular markers, and that's where this diagnostics approach is, because we're looking at what's on, what does the cancer cell, what's it expressing, what's it showing, and does it light up when we target that with an antigen?
Right.
And then those patients, if it lights up on a scan, then the likelihood that they're going to benefit from that treatment, because it's targeting that exact area or those cells, is very high, right?
Man, I need 4 more shows specifically on this. Like I'm a little bit lost right now, so I'm going to go back and watch this. And it's a good thing. It's really a good thing, because you're talking about things that are brand new that we can explore more in 6 months from now, 8 months from now. And yes, you're retiring, Sir Vogelwe, but you're going to be back. You better be.
We'll be in touch.
We'll be in touch. Exactly.
That gentleman that you just talked to?
Yes, Dr. Spear.
He's taking over the clinic.
Okay.
And he's a smart guy.
Yeah. Oh, yeah. He's a smart guy.
Not that
Well,
smart.
no, I love, but what I've thoroughly enjoyed through the years is the teamwork when it comes to all this. You know, the urology, the oncology, both radiation and chemotherapy and radiation. But it's so fascinating to me, all the new stuff that's happening. And we're kind of running out of time. So is there anything that we have not touched base on yet that you want to talk about really quick before we end the program? he giggles. How many days do you have?
You know, I think the most important thing from this is, number one, if you're over 50, get tested.
Yeah.
Okay. And then let us take over.
Mhm.
Okay.
Mhm.
And I guarantee that if you let us take over, you're going to be treated just as good as any place else.
Mhm.
Okay. I'll never
If
ever
not
claim
better,
that.
honestly.
I'll never
It's so
ever claim that I'm
personalized.
better,
Yeah,
because
well, yeah.
there are a lot of really good people out there. But I think I do a good job. I definitely think he does a good job.
Mhm.
And we've been blessed.
Mhm.
We've been blessed with a group that's very supportive, and we've been blessed with the planning, and we've been blessed with all the things that we've done to benefit our patients.
And you guys really are patients first, all day, every day. I mean, I remember, again, just talking to you from the beginning. Dr. Mendel, is there something that we can cover in the next couple of minutes? I know there's a lot of stuff to continue still, but what else would you like to bring up before we close up?
Yeah, I mean, I guess I can just piggyback on what Dr. Vogel was saying, that you know, we have an amazing team. You know, we have people like, it's not just my center. I mean, we're all about putting the patients first, and that kind of brings the whole team together, because we have a common goal. We're trying to help these people, and it's really like, it's almost sometimes like I don't even feel like I'm at work. Like I don't feel like I'm working. I'm just like, I'm there. I'm with my, you know, it's almost like a family there in my clinic. When we're there, we're getting this hard work done. But that kind of percolates throughout the whole group. You know, from the partners. I'm sure it's like that in everyone's clinic, where it's, you know, you're there with it's like your friends and family, and you're all trying to like solve these problems. And that's kind of the magic of the group. Yeah. It's really, you know, everyone's like this.
Well, it's palatable. I mean, just listening to you guys and being around you. And again, Rio Grande cancer specialist underneath the umbrella of Rio Grande Urology. I want to say thank you very much to our audience for continuing to join us. Again, this is the El Paso County Medical Society's El Paso Physician. And if you want to watch the show again, you can go to several places. You can go to pbselpaso.org. You can also go to the El Paso County Medical Society, which is epcms.com. And then easy also is youtube.com. On all of these, just look for the El Paso Physician. And if there is a specific program you want to find, just put that into the search engine. Also, if you have a question that you would like for any of the doctors from any of these shows to answer, feel free to text that in. You can bring in the question, and that is epmedsociety@aol.com. So I'll repeat the way that goes: epmedsoc. And that's at AOL.com. You can text in a question or email in a question, and we'll get the doctors to get back to you on all this kind of stuff. I'm Catherine Berg, and you've been watching The El Paso Physician.